안녕하세요. 리치널스와 함께 배우는 업무 영어. 오늘은 첫 번째 주제로 다양한 액센트를 가진 간호사들의 인수인계를 다루어 보도록 하겠습니다. 미국 병원에서 일하다 보면 다양한 나라 또는 다른 주에서 온 의료팀 멤버들과 소통을 해야 할 경우가 많죠. 같은 한국말도 지역마다 억양이 다르듯이 똑같이 미국에서 태어나고 자란 사람들도 어느 지역 출신이냐에 따라 같은 영어라도 액센트의 차이가 있기도 하죠. 영어를 제2 외국어로 하는 경우 모국어의 영향을 받아서 강한 액센트로 인해 알아듣기 힘들 때도 있죠. 하지만 익숙하지 않은 억양이라도 자꾸 듣다 보면 적응이 되기도 하는데요. 서로 다른 악센트를 가진 간호사들의 인수인계 상황들을 우리 함께 들어보아요.
This is Tori from MaidServe. Can I speak to the nurse getting Ms. Evie in room 123?
Hi, that's me, Obo. I'm ready when you are.
Great. Ms. Evie is 89-year-old female who is getting admitted to MICU for sepsis. She is full code. She was admitted initially on 27th November for a fall from a nursing home. Patient is lethargic, baseline oriented times 3 but now oriented to self only. At 10 a.m., her vital sign was blood pressure of 75/54, heart rate of 110, respiration of 22, and temp of 102. She was arousable but lethargic, noticeably compared to yesterday. 2 liters of NS bolus was given without much improvement. Repeated BP was 81/57. They are starting her on a pressor. That's why she's getting transferred to MICU. Evie is allergic to morphine, but it's a history from 20 plus years ago. And the patient doesn't know whether she has it anymore. She has a history of hypertension, arthritis, depression, and AFib on Eliquis. Evie is on room air. She has been on telly and it showed rate controlled AFib. She's on Zol now and her heart rate is 99 showing AFib. Last BM is today and she is on a regular diet. She has fragile skin and has cuts on bilateral arms from the fall. They are covered with Mepilex. Sacrum is red but blanchable. She was walking with one assist and a walker before it all happened. Lactate, 2 sets of blood cultures, CBC and BMP was sent 30 minutes ago. Urine needs to be collected. Zosyn is running on 20 gauge right forearm IV and NS 100 milliliters per hour is running on 22 gauge left AC IV. Daughter, Lisa, is at the bedside and we are coming with the patient. If you have additional questions.
Thanks. Do you know which presser she will be on?
The attending was considering levo-fed, but I will double check.
Thank you. The bed is ready.
Mr. Smith is 78-year-old male with full code admitted with shortness of breath due to CHF exacerbation 3 days ago. Patient's medical history is CHF, hypertension, diabetes type 2, CKD stage 4, AFib, and angioplasty with stent times 1 in LAD in 2017. IV Lasix was ordered, but it did not help patient make enough urine output, so changed to Lasix and dobutamine IV drips. Last 12-hour urine output was less than 100 milliliters, and the bladder scan showed only 80 milliliters at the end of my shift. Patient is on BiPAP, and O2 sat is between 93 to 95%. Without BiPAP, O2 sat drops to high 70 to low 80%. Patient is on beta blocker to control HR and hypertension. His AFib was controlled with HR of 90s, but last night patient complained of chest pain, HR increased to 130s, and BP went up to 178/114. PRN nitro sublingual given 3 times, and I notified the attending, Dr. Einstein. Doctor ordered to DC dobutamine IV drip, EKG, and statropinin lab. PRN hydralazine IV for SBP higher than 160 and nitro IV drip to keep SBP lower than 180 are ordered as well. EKG showing AFib RVR with peaked T wave and no ST elevation. Lab came back with elevated troponin level to 894. This morning, K was 5.7 and BUN and creatinine were 88 and 4.55. K oxalate ordered and nephrologist consultation requested. Cardiologist Dr. Steelhat came early this morning and ordered heparin IV drip dose adjusted by the pharmacy and plans to do an angiogram today. NPO order just came in. But patient has not been eating since midnight. Also, TTE ordered. Patient is and O times 4 and SBA. There is a midline in the right upper arm and PIV in the left arm on AC, Lasix and heparin IV drips are running. PTT needs to be checked at around 11 a.m. No BM yet. Family wants to speak with the attending doctor when they visit this morning. Do you have any questions?
Is the patient still having chest pain?
Pain level decreased from 10 out of 10 to 3 out of 10.
So, the nitro IV drip is not running now.
No, BP is now down to 150s over 90s.
What is the heart rate now?
After dobutamine IV drip stopped, HR decreased to late 90s to early 100s. Patient has a morning metoprolol PO scheduled.
Has the patient had a bowel movement?
Not yet.
Any edema on extremities?
Yes, bilateral lower extremities got moderate edema.
Has the cath lab or echo called yet?
No calls from cath lab yet. You know echo won't be open until 8 a.m.
Okay, I will check with them later. Thanks for the report.
TW is a 48-year-old male who was admitted 2 days ago on December 1st through the ED. Full code. He was found on the street, unresponsive. He does not remember collapsing. CT head was negative. He had an episode of agitation overnight and started screaming and kicking. PA was paged and HODL 2 milligrams. IM was given once at 4 a.m. which helped him calm down. He is on 1-to-1 for agitation. Bed alarm is on. No known allergies. He has a history of hypertension, type 2 diabetes, coronary artery disease and schizoaffective disorder. He is alert and oriented times 1 to 2. He is on bed rest now due to agitation. On room air. Not on tele. Last bowel movement was yesterday, on December 2nd. He is on a carb-controlled diet. He is incontinent of urine and stool and has a condom cast on. He has generalized bruising since admission but no open skin or active bleeding.
Is Haldol PRN?
That was one time. TW has PO risperidone PRN available if he is agitated again.
He can take pills whole?
Yes. If not, crush it and give with applesauce.
Do nurses draw blood in this hospital?
Phlebotomists usually do, but the patient has a midline on right arm so you can draw from it. Are you a traveler?
Yeah, I am.
Oh, I used to travel too.
Oh, nice. Thanks for the report.
Jane is 93-year-old female admitted with shortness of breath due to respiratory failure 5 days ago. Chest x-ray done and pneumonia in the lungs. So patient is on IV antibiotics. O2 sat is staying 90 to 92% with a non-rebreather mask. Attending ordered BiPAP, but patient could not tolerate it. Patient's heart rhythm changed to AFib and rate went up to 150s. TAE monitor and diltiazem IV drip is ordered. Target HR is less than 100. HRs around 90 to 100s with the drip rate maxed at 15 milligrams per hour. Patient is disoriented by place, time and situation. Patient keeps pulling her mask off, so there is a 1-to-1 sitter to reorient the patient. Patient failed swallow evaluation multiple times. The speech therapist found that the patient keeps aspirating when trying to drink water, so patient is NPO now. Code status changed today as the patient's POA agreed on DNR after meeting with the palliative care team. POA is not ready but possibly moving on to comfort care tomorrow.
Where's the IV access?
Patient got a pick on the left arm when she had D5W with KCL, heparin drip, and diltiazem drip. Oh, I forgot to tell you that patient had a echo and EF was 60% on the second day of the admission. No issue with the heart. So the cardiologist signed off from the case as the heparin IV drip changed back to oral Plavix.
So, her tachycardia was not because of the heart.
Not by the cardiologist, no.
How does she do BM and urine?
She has a Foley cath due to retention. Output was about 500 milliliters only as she does not eat or drink. She had a small BM today.
Any pain?
Patient does not say she has any pain, but she does not seem to be comfortable. I paged the attending for something to help patient be more comfortable. No answer yet.
Okay, I will follow up.
Do you have any questions?
No, thanks for the report.